So I'm getting excited to start. So I know that I said 2 minutes and it's been less than a minute, but I'm excited to start. So welcome everyone. My name's Jackie. I'm a third year medical student down here in Florida. My passion is cardiac surgery. So I'm really excited to be here to talk to you about anything heart related. I know last week we did heart transplant. This week we're gonna do LVAD. So I'm super excited to talk to you guys about it. As always, for those of you who don't know me, please feel free to unmute and answer any questions. I ask a lot of questions during the session, but you're also more than welcome to answer in the group chat, which I'll be monitoring throughout the session. I'm going to send the link again for the quiz in the chat, but I think it's also attached to your session notes. So please keep that open as we're going. It's a lot easier if you fill it out as we go. But yeah, so let's get started. But yeah, please let me know if you have any questions, comments, concerns, whatever. Let's go. Okay, so I just wanted to start with this picture. I don't know if anybody here is a fan of trash soap TV, but I watch Grey's Anatomy and I'm not afraid to say it. And so if you've ever seen the show, there's a character named Denny Duquette who has an LVAD, and then, yeah, and he gets his LVAD wire cut very famously on the show. So we're actually talking about that very same device that he has in his chest. So if you were ever curious about that, that's what we're talking about. And if you don't know Grey's Anatomy, ignore it. Your life is probably better without it because it is a deep, dark sand hole that you fall into and never get out of. Okay, so session outline, we're gonna first go over a case, and then we're gonna do the physical exam, go through some differential diagnoses, which should be pretty straightforward for this topic. Assessment and plan, and then we're going to talk a little bit about PATH. So your role, actively participate if you can. Again, I'm never going to cold call in anyone in the chat or from the participants, but you can always unmute and ask a question or send anything in the chat. And then fill that SOAP note out. If anybody has questions about subjective, objective, assessment, and plan, please let me know. We usually go over it at the beginning of the session. So does anybody really quickly want to go over what goes in subjective and what goes in objective? Just quickly, if anybody here, for anyone here who doesn't know. And I'm sorry for those of you who've been through this with me a lot of times. You've probably heard this ad nauseum, but now you'll know when they ask you. Symptoms go in subjective, signs, imaging, tests, and objective. That's absolutely right, Parab. So anything that the patient says or that you elicit from the history goes in subjective, and then he's exactly right. Physical exam, vital signs, imaging, and any sort of labs that we take are all going to be objective. Assessment and plan are a married couple, and they always kind of come together at the end. All right, let's jump into it. This is the SOAP note, which you should all see. Okay, so Dr. Duquette, his name is Mr. Duquette. Mr. Duquette is, he can be a doctor, maybe he's a PhD in something. Dr. Duquette is a 35-year-old man with a history of dilated cardiomyopathy who returns 3 months following an LVAD placement. During rounds this morning, he reports that he's feeling unwell and is short of breath. So this is obviously not Mr. Duquette unless he's aged very poorly. But this is basically what an LVAD is, and we're going to talk about this a bit more. So, but basically, this is the left ventricle, left atrium, right ventricle, right atrium, and we're basically pulling blood from this failing ventricle and we're putting it directly in the aorta rather than it going from this chamber up the aortic valve into the aorta. We're just kind of bypassing it because the indications for LVAD is going to be this ventricle basically is not contracting properly, which is why we need a device to basically do its job and push that blood into the aorta. I hope that makes sense. We'll talk about this again, so don't worry. Oh, did everyone have that information in their SOAP note? Yes, awesome. So are there any questions that we want to ask Mr. Duquette? Could I go back for a sec? Yeah, I think I can. Here. No, it's all good. All right, we're gonna keep moving forward, but if you have questions, let me know and I can always go back. So are there any questions that we want to ask Mr. Duquette now that he's here at our hospital? This is for his history. Think about things that we'd ask. This is kind of an unconventional case. I know normally we have someone coming in for the first time, but I thought it was kind of tired to do another heart failure case, which is why we're doing it this way. So, but treat him like he's a new patient coming in. So we're going to ask him very similar questions to those that we'd ask a brand new patient. Anything he did that triggered his symptoms that morning? Great question, Devani. So he's been kind of progressively developing these short of breath feelings and just kind of been feeling progressively unwell since about a week or so after the surgery. He thought he was just kind of post-operative tiredness, but it's kind of continued and in fact gotten worse. Smoke, exercise. So he definitely did smoke for a long time. He says he quit right before the surgery, and he says he hasn't smoked since, but that's only been about 3 months. And ordinarily he exercised pretty regularly. He had dilated cardiomyopathy, so he hadn't been moving around for a bit leading up to the surgery, and then he's been mostly resting since. So not as much exercise. Pain, he's got a little bit of chest discomfort, but he wouldn't really call it a pain. Nothing sharp, not stabbing, not really looking like a heart attack picture very much. But no, like none of that classic substernal chest pain. Medical history, really just the dilated cardiomyopathy, but he's not diabetic. No history of high blood pressure, no asthma, no other real chronic conditions. His only real thing was his heart. What medications is he taking? So he was given blood thinners when he was discharged from the hospital. He's been healthy his whole life. He was on a couple meds for his heart failure, but they kind of tried to take a couple of those off when he went into surgery. So he was discharged on a blood thinner called Coumadin, which is also called warfarin, when he was discharged from the hospital, but he's had some trouble taking it. He hasn't been taking it every day. He's had some trouble getting to the pharmacy since he can't walk. He's been really tired. So he hasn't been taking his warfarin. But other than that, he doesn't really take any medications. Anything help or relieve these symptoms? Not really. He's been trying to just kind of sit in his chair and rest. But he, hasn't really tried taking any meds for it. He's really just been trying to rest, but nothing's really helping. So that's why he's here today. Has he had any leg tenderness? Parab, great question. Why are you asking if he had leg tenderness? I'm sorry, I promised I wouldn't cold call. Does anyone know why leg tenderness? Okay, good. Yeah, so we're looking for DVT. Perfect. Y'all are right. You guys are very sharp. So leg tenderness or calf pain is classic for a DVT or a clot in one of those deep veins of the calf. We may also see unilateral calf swelling is another classic sign of a DVT in the leg. So we would absolutely need to check his legs. But no, he's not had any leg pain or swelling. And he has not coughed up any blood either, which is a great question. PE is definitely possible if one of those clots were to travel up from the deep veins into the lungs, which is an excellent question and something we always need to consider after surgery. Any other questions? You guys have done an amazing job eliciting most of the history from him. Okay, these are most of the things that I had questions about, was like, did he have any comorbid conditions? Is he asthmatic, diabetic, obese, anything? You guys covered that though, you're great. Post-operative meds, you did amazing. What was he discharged with? Really just the Coumadin. And post-operative environment, I did this because I'm lazy. And this is really like, has he been around a lot of dust? Has he been smoking? Has he been sitting? And you guys elicited all that information as well. No. Okay, patient reports that he's not been taking his Coumadin as prescribed due to difficulties getting to the pharmacy, and he's been mostly sitting in his chair at home. We talked about this. Progress. He quit smoking since the procedure. He denies any fever, chills, cough, or sick contacts. Past medical history is the dilated cardiomyopathy. He's got no autoimmune conditions. Bonus question for the group. Any reason in particular we might ask about autoimmune conditions? This is a very tricky question. Lupus is an autoimmune condition, and that is a classic one we'd be asking for. Or ITP. ITP is, it's kind of autoimmune. ITP is an excellent one, especially if we're concerned about bleeding, which is very, 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 very good of you to ask about. You know, ITP is pretty close to around what I was asking for. So autoimmune conditions can lead to a state of hypercoagulability, which basically means in a lot of autoimmune conditions like lupus, or there's a couple others, we won't go into it, it's out of the scope of the session, but autoimmune conditions can predispose to clotting. And so especially since he hasn't been taking his Coumadin, which is a blood thinner, that would kind of exacerbate risk of any clots forming if he were to have an autoimmune condition. So when eliciting the past medical history from a patient, it's important to not only ask, what do you have? But sometimes asking what don't you have is important because they may have one of these conditions, but like sometimes they don't really see it as a chronic condition, or like maybe they don't see a specialist for it, so they may not say it, which is why it's always important to ask. Non-contributory family history. He had smoked for 20 pack years. Does anyone remember from last week what a pack year is versus just saying for 20 years? Because we remember he was 35 and hopefully he hasn't been smoking since he was 15. Well, maybe he's been smoking since he was 15. I don't know his life. 1 pack a day for 20 years. Yes, 1 pack a day for 20 years is absolutely a way to do a pack year. Pack years is a weird way of math that we put in a lot of charting. So 1 pack year is 1 pack per year. Could be 2 a day for, perfect. So this is more so what I would assume for him. So it could really be either 1 pack a day for 20 years or 2 packs a day for 10 years. So we would want to ask him. It could have been something in between for 15 years. But this is a great way to characterize risk for a patient, because I've had patients come in with like a 70 pack year smoking history and they're 50. So it's a nice way to do the math, and it helps us to quantify. Yeah, I know, right? I was like, this must be a typo. It wasn't. They had COPD. So any questions about this family history? Yeah, right. Any questions about this? Make sure this goes in your SOAP note. And someone let me know when we're ready to keep pushing forward. I know we've had some new people join us since the beginning. I apologize, I haven't been monitoring the participant number. If you guys who recently joined us don't have access to the SOAP note, please let me know and I will resend the link in the chat. Also, welcome. Just let me know when you're ready to move on. But I want you to have the opportunity to fill out your soap note. Are you able to send the soap? Yes, I am. There's the link. No problem. So quickly, things that you missed. He's 35. His name's Mr. Duquette. History of dilated cardiomyopathy. Oh, it's right here. And basically, his chief complaint would be fatigue and shortness of breath, basically. No, it wasn't really fatigue. He was feeling, quote, unwell. It's if a patient uses a word that like specifically describes their symptoms, always put exactly the word they used in quotes. So that way we're not just saying they feel unwell, but if they say like, I feel like, quote, an elephant is sitting on my chest, I always write exactly that and put it in quotes because sometimes it's helpful, especially if it sounds kind of, for lack of a better word, if it sounds kind of like silly the way that they said it, I like to put it in quotes so that way I don't get reamed by my attending. Questions, comments, concerns? Let me know and we can keep moving. I had a patient the other day who said, I think my heart's just gonna stop beating spontaneously. He was like 30. And I absolutely put that in quotes because I don't wanna have to explain that. Yeah, that's a great point, Liz. Are you guys ready to keep going? Awesome, thank you. Okay, so here's his physical exam. We've now moved into objective. So his temperature is 38, he's afebrile, his BP is 110/80, which is a touch low. His pulse is 104. Normal, abnormal, the pulse? Bit high, yeah, just a touch high. 100 is right the line that we draw tachycardia at. What's the line for bradycardia? Anyone know? 60, perfect. So yeah, he's a touch high, and that's kind of correlated with his BP being a bit low. And his O2 set is 95 on 2 liters of nasal cannula, which is that little thing that goes up in the nose, which is a touch low as well, especially if he's on oxygen. So he's in moderate distress, sitting upright. This is a focused physical exam. His chest showed a normal S1 and S2. Does anyone remember from last week or just happen to know what S1 and S2 represent? Again, since this is after all a cardiac session. SA node. So SA node is a good guess. SA node is part of the conduction system. S1 is closing of the AV and S2 is closing of the SL. Okay, so it is the closing of valves, which is absolutely right. AV is also a node. We have the SA node and the AV node, which are part of the conduction system. S1 is closing of the AV valves, S2 is of the semilunar. These are all very close guesses. So the S1 is for the closure of the mitral and the tricuspid valves, and S2 is for the closure of the aortic and the pulmonic valves. So these are closing of the valves. We should have only 2 heart sounds, which is good. I'm just gonna leave it at that. We can have adventitious heart sounds. We can have S3 and S4. That's a whole other discussion. And those typically represent pathologic states, hearing the S1 and the S4, which just means that the blood is sloshing around in the heart in ways that's causing other noises to be made apart from the closure of the valves. It gets really complicated, and I can do another session on heart sounds later. Regular rate and rhythm, which means that he had no arrhythmia, which would be an irregular rhythm, like AFib would be a common one. The PMI, which is the point of maximal impulse, which is basically if you were to feel on your own chest in the middle of your clavicle, if you were to go down on the left to like the 5th intercostal space, you should feel a point on your chest where you can feel your heart kind of beating against the chest. And that's the point of your heart at the bottom, where it's kind of like leaning forward in the chest wall against the chest wall. So we can feel that, and it should be right in the middle. But in people with dilated cardiomyopathy, like Mr. Duquette, it actually, it is laterally displaced, good. It should be laterally displaced because the heart got big, because he had dilated cardiomyopathy. And a systolic murmur, at the left fifth intercostal space. Does anyone remember what the difference is between systole and diastole, the two phases of the cardiac system? It's okay if not, we can go through it. Systole is when the ventricles are working. Yeah, pretty much. So the ventricles are those two chambers at the bottom. Systole includes ejection and isovolumetric contraction. That is absolutely right. That is a textbook answer. So when the ventricles contract and push blood up into through the aortic valve into the aorta and through the pulmonic valve into the lungs, respectively, that is called systole, and we have it is called isovolumetric contraction, which means that it is the chambers, they should be uniformly contracting. And diastole, as Matthew was saying, is when we relax those chambers and they are allowed to fill with blood through the mitral and tricuspid valves. So that is correct. So basically we are having a murmur as the blood is pushed up, the ventricles are contracting and the blood is shooting up through the aortic and the pulmonic valves is when we're hearing that murmur, and we're hearing it kind of right around where the PMI should have been, kind of there at the base of the heart. The chest is clear to auscultation, no wheezes, and there is no pedal edema. No swelling of the legs. Questions, comments, concerns? Let me know when we're ready to move on from the physical. In the meantime, anyone have any thoughts or theories about any of the abnormal findings on the exam or any of the pertinent negatives on the exam? Pertinent negatives meaning things that I said in the things that I've written here that are normal, but that might be, it might be important for us to know that they're normal, rather. It's cool if not. Some stuff I just write because I write it. His temperature is normal. Yeah, Stephanie, why do you think it's important that his temperature is normal? Fever, yeah, sickness. It's a great point. He had surgery recently. It's super likely, not likely, but something that can happen. Yes, exactly. Tornika. We want to make sure that he's not having an infection. Now we'll confirm that with other labs, but it's a good sign for him that he's not febrile. Wonderful. His lungs are fine. Madeline or anyone, any idea why it's a good sign, or maybe it's a bad sign? I don't know. Why his lungs are clear. Rule out something like COPD. Yeah, for sure. He does have a pretty big smoking history. It's nice for us to think, again, the heart and the lungs are a married pair. So something that looks cardiac could be lung, and something that looks lung could be cardiac. And so we want to make sure it's not COPD. We'd hear wheezes. Parab, I like your point about pneumonia. Again, we're looking at the temperature, and we would probably hear we might hear evidence of some sort of consolidation in the lungs if it was pneumonia, which is a great point since he was recently in a surgery. And no post-op edema is also a good sign. Devani or anyone else, why is the edema, what if he had edema, what might that point to? Heart failure, perfect. He is a heart failure patient, so this could be like him developing heart failure again from the pump either not working or his heart, really it would be the pump not working. If he were to be developed, perfect. Uraj, Urja, that is exactly correct. If he were retaining fluid, then that fluid could extravasate from the veins and cause edema in the legs. So those are both absolutely correct answers. It is heart failure causing fluid retention. Perfect. Ready to move on, everyone? Woo. Okay, so what are we thinking might be going on with him given his labs so far? I haven't given you, not his labs, his physical exam. I have not given you the labs yet because I think that we're getting close. Let's remember he had unwell feeling, shortness of breath, clear lungs. He had a bit of a murmur on the exam. Murmur basically just means that there was turbulent flow somewhere in the heart. What is the likelihood that something would be wrong with the LVAD itself? Madeline, this is an excellent question. LVADs are machines, they are pumps, and it is very, very likely that this could be a pump failure. Into the pump and one from the pump into the aorta. And so if we were to develop a kink in that kind of C-shaped LVAD device, that would certainly lead to problems. Or if the pump itself had failed, maybe a clot inside somewhere, like a mural. Parab, wonderful, yes. So we could definitely have a clot somewhere inside the device, and we are going to talk about clots in a bit. So this is another great point, and especially since he's not, yes, Yulia, this is exactly right. He has not been taking his warfarin, which was a huge, huge, huge hint in his history. Even if he hadn't, there's still a likelihood of forming clots following any surgery, but he's not been taking his warfarin as prescribed. He's not been thinning out his blood, and therefore a clot is super, super likely, which could be causing failure of the pump. So you guys are actually all pretty much spot on. Aortic insufficiency from outflow graft of the LVAD. Yes, you can have aortic insufficiency, also called aortic regurgitation, meaning that the valve that goes from the left ventricle into the aorta could be basically not working as the one-way valve it should, and some of that blood is basically regurgitating back into the ventricle. And some of this could be because as we're pumping blood into the aorta from the LVAD, overfilling that aorta just above the valve can kind of cause increased pressure and can cause backflow, which can cause aortic insufficiency and or aortic regurgitation, which are the same thing. Great thoughts, everyone. You are all actually very, very, very astute. Well done. What labs or imaging would we like to confirm some of these diagnoses or rule them out? Now that we've got a pretty good picture of what this might be. We're thinking pump failure. We're thinking maybe kink in the wire. We're thinking maybe clotting. We're thinking maybe valvular insufficiency. Would an EKG be helpful in any way? So I'm going to be honest with you, Stephanie. We do EKGs on pretty much everyone. So the right answer in the hospital is always EKG. Do we need an EKG to confirm what we think this is? No. Will we probably do one? Yes. Because why not? I mean, it's cheap, it's easy, and it's an easy way to get a good picture of the heart. We are probably going to see evidence of heart failure here because it takes a long time for the heart to remodel. But we don't expect there to be any conduction delays. So we're probably going to get one because why not? Yulia says echo and coagulation panel. Absolutely. An echo is a great way to get a dynamic picture of fluid flow through the heart and the valves. Since we think valvular insufficiency might be up there, sure. And a coagulation panel is probably pointing at the clotting that we're seeing and also his not taking the warfarin. You're absolutely right. We're going to get a picture of how his blood is clotting with the coagulation panel. Can an ultrasound see through the LVAD material, or will it just be artifact? Parab, this is a great question. This is actually why it's kind of hard to get an echo on some of these patients, because going through echo through dense material like a rib or like an LVAD device, which is a dense opaque material, it's going to be hard and it is going to cause a lot of refraction. So we would like to get an echo on these patients, but we're also going to need other imaging. You're absolutely right for that reason. BNP is a good marker of heart failure. So yes, we would maybe like to get a BNP as part of his metabolic panel. Troponins, Urja is a great point. Troponins are a great marker for cardiac ischemia. So if we thought that maybe some of this clotting that we presume might be happening could have caused an MI or a myocardial infarction, then we may see evidence, we may see elevated troponins. And D-dimer per ob is another great one, and that is a marker for breakdown of clots, which also kind of tells us if there is a presence of clots. I hope that makes sense. Like if there are clots, then they're being broken down dynamically by the body. And so if we see evidence of clot breakdown, which is D-dimer, D-dimer is a great show for, do we have a DVT, as we mentioned with the unilateral calf swelling or pain, or a PE, which is deadly, pulmonary embolus. Invasive contrast imaging, you are absolutely intuitively right on this one. We are probably going to get some larger type of imaging on this patient. We want to look, since it might have been you brought up that it might be a kinked tubing of the LVAD, we want to see if it's kinked. We want to see, how does the tubing look? How is the device sitting? Is it even working? Absolutely right. You guys are all spot on. So here's his chest x-ray. This is a pacer, which we didn't talk about because this is a picture from Google. So, but this is the LVAD itself. So here we have a huge, huge heart, should only be taking up about 50% of the in width. So this is huge. This is a huge heart. This is the left ventricle over here. And again, we're pumping blood out through this pump and up into the aorta up here, which we can't really see. These, does anyone know what these are? These loops right here. Sternal wires, yeah. So these are wires that we use to close his sternum because this was an open heart procedure. Yes. Well done, everyone. And then these are all of just his wires. He has an EKG running, and these are from the pacer and the LVAD. This is the LVAD wire. That's the big guy. All right. Well, we just did that. Okay, so on his echo, he had normal left ventricular dimensions. His aortic valve was not closing very well. Well done for the aortic insufficiency, despite increasing pump speed, meaning that pump is trying to compensate for the fact that we're still spilling blood back into the ventricle. But it's not working. The valve is still kind of regurgitating back into the ventricle. We have an elevated serum lactate dehydrogenase. So for those of you who think that it's just a bunch of noise having to learn all this biochemistry, any theories about why we might see an elevated lactate dehydrogenase in a patient like this? This is kind of a very challenging question. Or what settings do we see lactate dehydrogenase? And think back to your metabolism lectures that we all inevitably took. This sounds like a Krebs cycle question. I know, which is the worst cycle. I saw a meme that was like the real Krebs cycle is relearning the Krebs cycle, which is true. Ischemia. Yeah, you guys are absolutely right. So when we have participants can now see your application. I don't know what that means. Yeah, this is all very good. So basically in the setting of anaerobic metabolism, meaning we're not oxygenating well. Look at this hemoglobin. This hemoglobin is very low. So if we're not delivering oxygen well, remember his O2 sat was 95 on 2 liters of nasal cannula. So he's not oxygenating well, which means that the body is instead breaking down. Do you remember what is being broken down to form lactate dehydrogenase? I'm not just trying to be mean. I have been pimped on these questions during rounds. So this never goes away. I'm just sorry to be the bearer of bad news. Anyone remember where lactate dehydrogenase comes from? It's pyruvate. It comes from pyruvate. I don't know. I've been pimped on it, so why not spread it around? So yeah, basically these are all markers for poor oxygenation. Here's the chest X-ray. And his hemoglobin is quite low, which could be a number of things. Low hemoglobin is likely bleeding. And chest angiogram, angiogram meaning that we're shooting dye in through the arteries to better visualize them. So we're seeing acute angulation of the outflow graft and narrowing of the lumen of the outflow cannula from extensive thrombus. I think someone actually said thrombus within the device, causing pump failure. And let me tell you, you guys were spot on. So these are all going to continue to go in objective findings. Someone let me know when you're done typing. Just finished. Awesome. Thank you, Brittany. Okay, so this is our CT that we saw. So again, we're seeing blood coming up. Sorry, this is not blood, this is the device. Blood is coming up here, but look how narrow this is, this lumen. This dark part is clot. So we're seeing blood come up, but it narrows here. This, guys, was our systolic murmur that we heard. I remember I said turbulent flow, or not, meaning non-laminar flow caused by any sort of anything wrong with the vessel through which fluid flows through, is causing turbulence probably right around here, which is causing when it contracts, we'd be seeing murmur happening right over there. So we're seeing this big kink in the wire here. This is the angulation, and this is the giant thrombus that we're seeing. Okay, so assessment and plan. Basically, this goes again in the SOAP note. We're going to see his big problems. I think were 3-ish, mostly just the one though. He's having pump failure. So treatment guidelines are recommending anticoagulation. So he needs to be started on heparin like now. And then we probably need to take him back for surgery. There have been some studies that show that we can do this endovascularly, but I say we just open him back up. So anticoagulation, surgery, we need to consult back with CT surgery, ideally whoever did his surgery before. And then after post-operatively, we'd like for him to follow up with the CT in a month just to make sure that everything is still copacetic. We're going to keep him NPO, which means none per os. So meaning he's not able to eat any food. Do you know why we're keeping him NPO? Yeah, exactly, Rob. We're probably going to be putting him back into surgery pretty soon. So let's just make sure he doesn't eat anything for now. Hopefully CT surgery will take him back. NPO means non per os. Per os, I think, is maybe probably Latin. Everything's Latin. So per meaning like through or like with, and then os is like your mouth. So nothing through the mouth is what it literally means. Yes, thank you, Stephanie. Exactly. Aspiration risk is a good idea too, but we like, if a patient can eat, meaning they're not going into surgery, we like to have them eat their food rather than giving them nutrition through like a peg tube, which goes directly into the stomach, or intravenously. But aspiration risk is a good one, and we definitely want to make sure he's not aspirating. And then we want to manage his pain. PRN means as needed. So if he's in pain, we want to just make sure that he's not in any pain now, but is pretty much the assessment and plan. So now we're going to talk about path. So your SOAP note should be done, but let me know if it's not. So now we're going to talk about ventricular assist devices. So we've been talking about LVAD, which is the one that I hear the most about, and probably the one that you've probably heard the most about. I don't know your life, so maybe not, but basically there are actually a couple flavors of this. We have the left ventricular assist device, a right ventricular assist device, and we have a BiVAD for both ventricles. So it just depends who's failing. Left ventricular heart failure is more common than right ventricular heart failure. And the most common cause for right ventricular heart failure is left ventricular heart failure, oddly enough, because the chambers all intermix so much. And so LVAD is probably the most common. I actually didn't look up the stats, and that's on me, but this is a great, so in recent years, it's become more than what it was in the past. This was initially created to be something that patients use as they're waiting for a heart transplant, because that's really the only treatment for end-stage heart failure is a heart transplant. But these devices have gotten a lot more sophisticated, and they're trying to make them better to last longer. So patients can actually use them as what's called a destination therapy rather than a bridging treatment. So now they can actually just keep the LVAD and not even have to wait for a heart if the LVAD is functioning well enough. So it's no longer just a bridging to heart transplant. It can be its own thing. We just need to monitor them very closely. Here's the LVAD again. So again, we're pulling blood from the left ventricle. It's going through this pump. This is the notorious LVAD wire. And then it goes down here through this pump. So this is where we had the thrombus earlier, and this was kinked, as you'll remember. And it goes right here into the aorta. The aortic valve, as I was saying, is going to be right here. So imagine if we're pumping way too much blood into here. Or imagine if this blood is actually being spit back into the heart, then this device is going to realize that there's not enough pressure here downstream in the aorta, and it's going to try to pump faster. Because instead of the blood all going this way through the aorta, whoa, some of it is actually spitting back. And so that was what they meant by the pump speed has been increasing, but it's not really helping. And he's still feeling fatigued because he's not getting enough blood to the rest of the body. So other complications of LVAD, the most common complication is bleeding, mostly GI, meaning in the gut or in the colon or in the stomach is the most common source of bleeding. But we can also get bleeding in the central nervous system, usually in the brain. We can get a hemorrhagic stroke in the brain. How would we detect bleeding in the belly, or that GI bleeding? Melena is a great one, Parab. What does melena mean? Black stool, perfect. Endoscopy, Matthew, is another great one to aid in help if they're bleeding into the belly. So these are all ways of saying that basically we're one big tube inside, which someone said to me and I can never forget it. It changed the way I see our digestive system and I don't really like it. But if we're bleeding into our big digestive tract tube, then some of that blood can kind of collect. And you'll notice that when you get a cut and that blood dries, it turns dark. And that's because of oxidation. And so we see this dried, not dry, yeah, kind of like dried blood that's poorly oxygenated because it's offloaded its oxygen and now it's dark. And as that continues traversing through the GI system and eventually becomes stool, that's why we get the dark stool down there. If we had bleeding in the lower GI tract, we would actually see bright red stool rather than dark red stool. So that dark red again means that because it was bleeding up higher in the GI tract and then had to go all that way and offloaded all its oxygen in the meantime. Nausea, coffee ground vomit is a great buzzword, Madeline. So if he's been bleeding, also nausea, because if we're having really low blood, then that could definitely cause nausea just in general. But coffee ground vomit also means that we had that kind of blood which reacted with the acid in the stomach and caused it to become dark. And then when you vomit it up from the stomach, that's why we see that dark classic coffee ground vomit. It means that there's bleeding somewhere in the stomach. Distended belly is a great one. So if we're like grossly bleeding, meaning it's no longer in our digestive tract tube and it's just like fully perforated something, some larger vessel has blown, we will see the belly start to grow rapidly. And sometimes it will even be a bounding kind of pulse that we'll see. Signs of peritonitis, Devani, is exactly good. This is what we call the signs for an acute abdomen. So if we're seeing rigid, distended, very painful abdomen bleeding in the GI system, perfect. So these are all things that we would look for immediately. And then we see thromboembolic events, which is what we saw kind of in our patient a little bit. So this is going to be, again, those clots forming somewhere around the device. Atrial fibrillation is a predisposing factor to clotting. Does anyone have a theory about why atrial fibrillation will predispose to clots? We might have touched on this last week, I don't remember. Because the blood is sort of, yeah, exactly. So when the atria, those two chambers on top of the ventricles, fibrillate, rather than pump normally in one contiguous motion, the blood that's supposed to be pushed from the atria into the ventricles just kind of sits there. And when it sits, it clots. So not only did we do this massive surgery, but if you continue to have the atria fibrillating, that's like a second risk factor on top of the first. So very likely to be forming clots in this case. So all the more important to continue on the anticoagulation. Infection, I remember we talked about the fever. So looking for signs of infection is so important after any surgery. LVAD specific complications, which we kind of saw a flavor of today with the device malfunction, pump thrombosis, LVAD associated complications like bleeding, cerebrovascular events, infection. Yeah, we talked about all of these. So these are all common things that we can see with the LVAD, but these are also a lot of common complications from any surgery. So now I want to talk a little bit about clotting, since that is the main problem with our guy. There's this thing called Virchow's triad, which you'll become very familiar with if you haven't already heard of it. It's a classic question to be asked on an exam, and also something that you will be pimped on, and people will be very excited and impressed if you still remember it. So there are three things to this: hypercoagulability, endothelial damage, and venous stasis. We've touched on a couple of these already, actually. So hypercoagulability, remember when we asked, do you have any autoimmune conditions? If he was a woman, we would ask if he's taking birth control or OCPs. Pregnancy, also malignancy, if you have a history of cancer, can all cause a hypercoagulable state. So that's the first. The second is endothelial damage, meaning that the inner layer of the vessels themselves, if they are damaged or sheared in any way, the damage of those vessels can also predispose to clotting. I will not get into the physiology as to why that happens. But if that is damaged in any way, and think about what a surgery is, we're cutting through the musculature, we're cutting through the vessels. So by the nature of the procedure itself, we are causing endothelial damage, we are shearing the cells, we are traumatizing the vessels. Any surgery is a trauma. And so we are causing endothelial damage. We already have one side of Virchow's triad. And the third is stasis. So stasis, this is what we just talked about with the atrial fibrillation, where we're seeing stasis in the atria. Also, if you've been sitting for a long time, a classic question we ask patients if we think they might have a DVT in the leg or a PE, pulmonary embolus in the lungs, is, or not really ask them, we don't see this in clinic as much, but PE patients are usually post-surgery patients or really old patients in like a nursing home. But in a test question, you're gonna see like, patient just came from a flight from Singapore. So long flights is a great buzzword. Sitting, bed rest. If this guy has been sitting in his armchair, Denny Duquette has been sitting in his armchair for 3 months, that's stasis. Or bus rides, or they've been like applying a continuous like lower back heating pad or something, or like, I don't know, some sort of heating pad. Singapore. Yeah, I know. Singapore sounds fun. So this is Virchow's triad. It's important to know, important to understand. And he already had, at least probably 2 of these. So now I thought we would just talk a little bit about clots forming and kind of some of the symptoms we think we might see with these clots forming. So we're thinking that if the clot had formed here in the left atria, where are some of the places that we think the clot might travel in a dangerous way if we had an arterial clot that formed in the atria or that formed in the LVAD that would go from here to here, just intuitively looking at the vasculature? Traveling to the brain is always really dangerous. Absolutely, Stephanie. So blood forming, clots forming here or in this device, it's very likely that the clot will go zoop up into the brain, especially if they have an atrial septal defect or a ventricular septal defect. So the reason this is being said, you are absolutely right, Parab, but let me make an addendum to this. So we worry the most about an ASD or a VSD, which is an atrial septum, which means it's the septum separating the right and the left atria, and the ventricular septum, which is separating the right and the left ventricle. If there's a hole in these, then clots can move betwixt the two chambers when they're here. So we actually worry about this the most with the DVT, because if the clot were to come up here from the leg, say, come up the, what is this? Does anyone know what the structure is called right here, this long one? This long boy? IVC, yeah, the inferior vena cava into the right atria and sit here. And then if it were to go, there was an ASD, it would go zoop into the left atria and can go whoop right up into the head, which is the most concerning. So we do worry about this. We can also have a clot form here and go zoop this way up the venous system, but we worry about that a lot with a DVT or a PE of them crossing here, because we're actually more likely, we see DVTs and PEs more often than we see like thrombus from an AFib forming, because the left side and the arterial side is such a high pressure system. We do see more clots forming in the venous system, and that's really because of this leg of Virchow's triad with the stasis. It's a lower pressure system in the venous system. So if you're sitting for a long period of time and the venous system is already low pressure and it's not moving as much, can like not actually getting up and moving and walking around with your legs or wearing compression socks causes you to be more likely to form clots in the venous system. So yeah, we definitely do worry about this. There's another classic test question that you'll get, which is like, it's called the PFO. It's the patent foramen ovale, which is a form of an atrial septal defect, which basically it's a specific hole that is between these two. Classic question of how can you get a stroke from a DVT? Because it doesn't really make intuitive sense, because the venous system, this is coming down. So if you had an arterial clot here, its only way to go is arterial up to the brain. So again, up here, crossing arterial brain. Other places that we can get clots, I mean, I guess hypothetically we could go this way or this way. Clots or things forming in the arms, again, are more likely to be venous in nature, just because of the lower pressure system. The main place that we're going to see clots forming in the arterial system are going to be in the heart, and then most dangerously up to the brain. Or importantly, you can't see it in this diagram, but the individual coronary arteries that supply the heart muscle itself come right off of here in the aorta. So the most dangerous places for them to go are up into the brain, or actually immediately down into the heart, causing an MI. So those are the most concerning things. One of the reasons I think actually I misspoke earlier and I said EKG is not important to do. One of the things that, which I shouldn't have said, we can possibly get an ST elevation MI that we could register on the EKG. So I just thought this was a nice exercise, and now we can see all of the vessels. So these are my sources. I'm going to take the last 5 minutes to answer any questions, go back to any slides that you want to see. I'm also happy to answer questions about surgery, medical school, cardiology, heart stuff, or whatever you want to ask about. The rest of the time is yours. Yeah, thank you guys so much for sticking around for this whole time and spending your evening or afternoon with me, depending on where you are. When we talked about valve replacements, you mentioned clotting on the replacement valve itself. Does that happen with the LVAD at the points of connection with the heart and the aorta? Madeline, this is a great question. Let me go back to a picture of the LVAD. So anything in the body that is not supposed to be there, even like a pig valve in the body, your body will immediately recognize anything that isn't organically self. So any sort of metal device or plastic device is prone to the body kind of recognizing it as other and forming clots around it. So we can actually form a clot anywhere along this apparatus. You're welcome. We can form a clot anywhere along this apparatus at all. Valves are a really good place to form clots because there's just so much blood flowing through them. And like we saw in Virchow's triad, endothelial damage, again, which we see in any surgery. I'm sorry, I was talking about something else. Yeah. Endothelial damage can cause clotting. And we can also clot anywhere along the device. I don't know where I was going with that, but yeah. Are the LVAD components coated with anything like heparin, or are they just bare? So there are some, so when we stent a vessel like in an MI, we sometimes coat the vessel in a substance called sirolimus. And so we can see that happen. However, the dangerous thing is that, okay, so the short answer is I don't know, and I'm trying to talk around it. So I'm not sure. I don't think they coat it in anything because I think you have to really weigh bleeding versus clotting. And so I don't think they would coat it. I think they would just have them take the heparin postoperatively, is my theory, because we don't want them to bleed. If we're trying to sew this to this, but we've coated it in heparin, it's possible that this would just bleed excessively. And then the anastomosis would fail, is my intuitive answer, but I'm not sure. If I'm wrong, please correct me. Which model of the LVAD is most commonly used, HeartMate 3? So I actually just did, just helped with a paper on this. So we're transitioning between the HeartMate 2 and the HeartMate 3. Right now, there are some notable differences. So there's been differences early. LVADs, there's been great contingency among the community about whether or not we do continuous flow or we do pulsatile flow to mimic the heart. So that's one of the major differences. Also, the motor itself is different in the HeartMate 2 and the HeartMate 3. I think we're seeing more HeartMate 3s now, but we are still putting out papers as the one that I was working on that do involve kind of trying to make an argument for why the HeartMate 3 might be superior. But again, one of the big ones is pulsatile versus continuous flow. So it's a good question. A while ago, I learned that LVADs can result in a patient not having a palpable pulse, not having cardiac arrest. Yeah, okay, this is exactly what I was talking about. So some LVADs are non-pulsatile LVADs, meaning normally we get a pulse because we have systole and the heart is contracting. However, in this case, we don't really need to contract the heart because the point of the heart contracting in systole is to push blood up through the aortic valve into the aorta. But if this device is pulling blood out and pushing it through the aorta, we no longer need to contract. And if this is pumping continuously without a pulse, then that's why we don't end up having a pulse at all. Does the heart not try to contract around since the blood is all moving away? So it's a good question. It's called automaticity of the heart because we do have an intrinsic conduction system. Many of you brought up the SA node, which sits up here, and the AV node, which sits somewhere down here. So we are still going to be sending electrical signals. But I think part of it has got to be the mechanical constraints of the device. I mean, even if it tried to contract, it's going to have a bit more trouble with all of this noise around it. But I do believe the automaticity of the heart. I don't see why that should stop based on the device. I think we're not gonna feel it in such a, it's not gonna contract as vigorously to the point with which we feel a pulse is my thought. Yeah, I think it's pretty cool too. Intermediate speed reduction with the HeartMate 3 can cause an artificial pulse too. Yeah. There's a lot of little intricacies with the device. There's been a lot of papers trying to figure out what the best way to do is, and it's really all just trying to tip the scales between clotting and bleeding, and that's mostly been it, because we've seen some issues with, yeah, we've seen some issues with trying different models of the heart. It kind of goes beyond the scope of the conversation, but it's they've been trying to make a lot of improvements with it. And I think that's because we're trying to use it more as a destination therapy versus a bridge. And we're trying to make the HeartMate or this LVAD device kind of more of a way to save more people in end stage heart failure, really, because we're seeing so many patients live longer with comorbid conditions and kind of get to this end stage heart failure while they would have died from other things or complications much earlier in previous years. So we're seeing a lot more end-stage heart failure patients. Therefore, we're needing a lot more hearts, but unfortunately, the demand for heart transplant far exceeds the amount that we have available. So if we were to really make this device last longer and decrease the number of complications, as is the goal with any device, then we really won't need to use it as a bridging therapy anymore, and hearts can really be reserved for the patients who cannot withstand LVAD placement. So I think that's the hope. And also what I encourage you to tell people who say that cardiac surgery is a dying field, because it's not a dying field. And I don't know any way that a cardiologist is going to be, yeah, I know, I've had like almost everyone has told me this, that cardiac surgery is not a dying field, because basically the thought is they're being replaced by interventional cardiologists, which is not a surgeon. They are cardiologists who can place stents in the heart, and they actually can do valve replacements. It's a really, really cool field, but they're not surgeons. Although they can do a lot of minor surgical procedures, sort of. They will never be able to do an open heart surgery. They will never be able to place an LVAD, and they will never be able to do like a CABG. Like they can never do an open heart procedure, which we will always still need. So don't let anyone tell you that. Take away the COVID pandemic. Yeah, fight anyone who says that, please. Take away the COVID pandemic. Chronic health conditions are the top concerns in pub. Yeah, exactly. So it's heart disease is the #1 killer in the world, more than anything else. So almost everybody has some form of heart disease, which means an exorbitant amount of people will develop heart failure, especially because our medical treatments have gotten so good. So a lot of people are seeing end-stage heart failure before dying. And some of them are seeing it at younger ages as well. And so these procedures will always be necessary. I don't know, I get pretty heated about this. Here in Australia, we had more training spots for CT than the applicants this year. I know, that's what I'm trying to say. I think the scale is gonna have to swing back one day. Also, the lifestyle for cardiac surgeons sucks, which is, I think, and interventional cardiologists live a pretty sweet life, and they're paid heftily. So a lot of people who were gonna do CT surgery are doing instead interventional cardiology, because it's semi-procedural and it's heart. It's about as close as you can get to being a heart surgeon without being a heart surgeon. And it's a really cool field. I encourage you to look into it. I've looked into it. But yeah, a lot of people are choosing not to do heart surgery anymore, which is really sad. Also less litigation. That is correct. Yeah, so don't let anybody tell you that it's a dying field. I think that it's a changing field because the interventional cardiologists are taking all of our procedures, but I don't think that it's ever going to go away. It's just going to have to continue to evolve. And I think that they're going to have to start, I don't know, they're going to have to just start making the lifestyle a little better for these cardiac surgeons, because their lifestyle sucks. I just did a presentation on health equity. Yeah, it's ridiculous, the lifestyle of cardiac surgeons and surgeons in general. It's not, you'll hear a lot about lifestyle specialties, quote unquote, versus non-lifestyle specialties. And let me tell you, I didn't really believe it until doing my rotations. I was kind of like, what is lifestyle? It matters. It does. It's a big factor. So so hold on. I'm getting some messages that I'm just trying to read. The same goes for optho. Yeah, that is exactly correct. The same is for optho. So it looks like I might have made a mistake on the quiz for question 6. What is question 6 on the quiz? Can anyone tell me? Once the surgery is done, how much will be the approximate lifespan of these devices? So it does depend. Usually it's only a few years before they need to be replaced, usually because of clotting or device failure. Again, we're trying to make these devices less prone to clot and less prone to failing after a certain number of years, because we are using it less as a temporary treatment and try to use it more as a lifelong device. But it's usually only a few years. My cardio is a bit weak. Can you please suggest some sources to straighten it? Absolutely. So I want to tell you that the cardiac system is one of the most complicated systems. It's also the coolest once you get to know it, and the most intuitive. I encourage you to, there is a book that is the best book if you want to learn how to read EKGs. It's called by a guy named Dubin. So if you just search Dubin EKG, oh, hold on, I sent that individually to one of the participants in this meeting. Sorry, Dubin EKG. This is the best book out there for learning how to read an EKG. It's quite extensive, but I had given a talk about EKGs and I pulled a lot of it from this book. This is an excellent book. There are probably a lot of YouTube videos. The one that we used a lot in medical school is called Osmosis, which is it's a video subscription service, and it has a lot of videos, but I think its cardiology system is the strongest. I think that's really good. There's a couple aspects of the cardiac system to strengthen. And so there's the kind of like flow and the murmurs and the valves bit, which is kind of going to deal with like the systole versus like the diastole of the heart. But then there's also the whole issue of the conduction system, which is kind of what this Dubin EKG book speaks to. And so that's what I would recommend. But because the osmosis system is really kind of made for students who are in medical school and it's expensive, I would try to find some videos on YouTube. When I email Becca about the question, I can also look up some YouTube videos and I can send them to her to send to you guys maybe about it. But I think that the most important thing with the heart is being able to visualize it. Because I think once you can visualize where the blood is going during systole and during diastole, when and where the murmurs happen, when and where certain electrical signals are being sent, and how that would register in the EKG begins to make intuitive sense rather than having to memorize. Like, this is why I don't like neuro. I don't want this to turn into a complaining session about neuro. But there are some systems like the brain that to me don't make intuitive sense at all. It's a lot of names, it's a lot of noise, it all looks the same. I don't know, I don't really understand it. But the heart makes sense. It's one big pump that's, you know, fueled by one big electrical system. And it's physics and it makes a lot of sense. So I think learn to visualize where the blood is going during each of the phases. And really there's contraction and there's relaxation. Is the blood filling one of the chambers? Is the blood relaxing into one of the chambers? And if you guys are interested, I'm going to be doing more of these sessions and I haven't decided on the topics for all of them. So if you're interested in me doing a session talking about just heart physiology and kind of going back to basics, let me know if that's something that you'd like to see. Okay. I can definitely try to plan one of those and I can just go into, awesome. So I would be more than happy to kind of go through step by step where the blood is going, where the valves are, talking through the conduction system. And I can definitely try to do that. So I will plan a future session about that. And for those of you who already know the cardiac system, it might be a good review. Or just, you know, you don't need to come to it. But yeah, I just think it's a cool system. And I think that if you can make it make sense to you, which takes a long time, it's really hard to kind of build the kind of have thought through it enough that it makes sense. And I still mess up every so often too. So it's going to take a couple passes of material, but I promise that putting the work in early and learning it and being able to visualize it is going to save you so much time. Okay, Bridget. Thank you so much for everybody who showed up. Absolutely. Yeah, I will definitely plan a session about heart physiology and talk through fluid dynamics, valves, anatomy, and the conduction system. I think that would be a good chat for us to all do. Yes, thank you all of you for showing up. I hope to see you for our next cardiac surgery or cardiology presentation, since that's all I know how to do. I hope to see you guys in future sessions, and let me know if there's anything else I can do for you. I'm always happy to answer questions about med school, cardiology, cardiac surgery, anything. So you can just ask Becca and she'll forward a question to me. Attacks are huge. As you know, it's again, #1 killer in the world is heart disease. So I think it'll be a good talk. We're going to talk through the algorithm on how to, identify and treat heart attacks. And so I think it might be nice. We'll talk about our brothers and sisters in interventional cardiology who do a lot of these treatments. And I think it will be good fun. So I hope you guys can tune in for that. Thank you all for being here. Hopefully I will talk to you all soon. Bye.
Night.
Night. Bye.